Hello, welcome on this session. We're going to discuss sulfonamides, that's sulfur drugs, and cotrimoxazole on this session. One of the important extended spectrum antimicrobial agents. And just to give you a reminder of the history, sulfonamide agent was the first antimicrobial agent of the world, which came around 1937 or 1938. That's sulfanilamide. So that's the historical importance of sulfonamides. Although they are not much used these days as sole agents, or they are not used as alone for treatment of infections, because many organisms have already become resistant if you use the sulfonamides as sole agent. So the chapter is sulfonamides, that's sulfur drugs, and cotrimoxazole. Sulfonamides are commonly called sulfur drugs. They are bacteriostatic. Please mind well, they are bacteriostatic. They have an anti-metabolite action. They inhibit the conversion of the para-aminobenzoic acid into folic acid. We'll come to the details later. So that's called anti-metabolite action. They have got an extended spectrum of activity. That's the usefulness against various types of microorganisms. They are largely plasma protein binding agents, very highly plasma protein binding agents. So you could expect certain drug interactions with sulfonamides, and sulfonamides are acetylated. So these two pharmacokinetic characteristics you have to remember is their highly plasma protein binding, and second one, they are acetylated. And depending on the genetic trait, there could be slow acetylators of sulfur drugs, just like some other drugs like isoniazid, then hydrolazine, procainamide. You could have slow acetylators and fast acetylators. So you could have this genetic polymorphism for sulfonamide group of drugs. Next, we go to the spectrum. They're useful against many gram-positive organisms. They're useful against many gram-negative organisms. What's the list of gram-negative organisms? We always start discussing with E. coli. So yes, E. coli, Proteus, Klebsiella, they're useful against these organisms. Then Haemophilus influenzae is another gram-negative, and Haemophilus ducreyi. Then Vibrio, Pasteurella, Salmonella, and Shigella. Look at that, many gram-negative organisms. E. coli, Proteus, Klebsiella, Haemophilus influenzae and ducreyi, Vibrio cholera, Pasteurella, Salmonella, and Shigella. They are also useful against Pneumocystis carinii or Pneumocystis jirovecii, and they are also useful against toxoplasmosis. In the recent age, this use has become very important for sulfonamide group of drugs, Pneumocystis carinii and toxoplasmosis. Next, they are useful against nocardia. They are useful against an atypical microorganism, that's chlamydia, and they are also useful against malarial parasite, that's a protozoa, malarial parasite. Only organism which is not inhibited by the sulfonamide group of drugs is Rickettsia. So don't mention of Rickettsia. Otherwise, have a look at the slide. Many gram positive, many gram negative. We already mentioned what are gram negative. And amongst the other variety of microorganisms, Pneumocystis carinii and Toxoplasma, then nocardia, chlamydia, and malarial parasite. Let's move on to the next slide, and let's have a look at this slide to understand what's the synthesis of DHF and its conversion into THF in the microorganism. Follow the cursor and look at the particular step I'm showing you. Para-aminobenzoic acid, that's PABA, plus dihydropteridine, there is formation of dihydropteroic acid. So from PABA, with the addition of dihydropteridine, you get formation of dihydropteroic acid. Glutamate is added to this dihydropteroic acid, and you get formation of DHF or dihydrofolic acid, or what you commonly call as folic acid or folate. So if you skip this small step in between, and if you just look at it as if this is the first step and this is the second step, so you can also write it as PABA to DHF or PABA to folic acid. So that's the first step. The second step is conversion of DHF, that's dihydrofolic acid, into tetrahydrofolic acid, that's THF. The other name for this, you can also call it folinic acid. So if you want to use this terminology, you could say PABA to dihydropteroic acid, dihydropteroic acid to dihydrofolic acid, and dihydrofolic acid to tetrahydrofolic acid, if you want to say it as it looks originally. If you want to comprise it a bit, then what you can say is PABA to dihydrofolic acid, straightway that's DHF, and DHF to THF. And to use simpler terms, you can call it as PABA to folic acid and folic acid to folinic acid. You won't be wrong even if you say it this way. Have a look at the inhibition, the sign of inhibition. PABA plus dihydropteridine, that's the first step, and then the further conversion into DHF is inhibited by sulfonamides. And look at the box. What are the various drugs which are going to produce inhibition at this step? There is sulfonamides, there is sulfones, and there is sulfonyl ureas. I am sure it's going to be easy to remember. Everything begins with sulf. Sulfonamides, sulfones, sulfonyl ureas, furosemide, that's the loop diuretic, thiazides, again diuretics, and acetazolamide is a carbonic anhydrase inhibitor. Please remember, most of the diuretics have got a sulfa structure, and that's why they have got this particular property of inhibiting the first step, that's PABA to folic acid or PABA to dihydropteroic acid. So that's regarding the mechanism of action of sulfonamide. So when they are going to deplete the dihydrofolic acid, a substance, a metabolite required for DNA synthesis, then we call it as anti-metabolite action. You can also call it as folate antagonist or antimicrobial agent. So that's the mechanism of action. Now just for your information, we may not come back to this slide, so I'm showing you here itself. The second step in this particular tetrahydrofolic acid synthesis is inhibited by certain number of drugs. And what are these drugs? Let's have a look at it. It's interesting. The first one is trimethoprim. And I hope you know sulfonamides are combined with trimethoprim to make cotrimoxazole. So sulfonamides act on the first step, trimethoprim acts on the second step, so it becomes sequential blockade. I'm going to say about it again, but let's have a look at the drugs which are inhibiting this second step, trimethoprim. The second important drug is methotrexate. Methotrexate is an anti-cancer agent, and this is a folate antagonist, and is going to produce the same action, that's conversion of DHF to THF will be inhibited in the cancer cells, and that there it becomes an anti-cancer agent. The next important drug which does it is phenytoin sodium. Phenytoin is an anti-epileptic agent, and this anti-epileptic agent and many other anti-epileptics like carbamazepine, valproate, they have got this action. But we are not using them as antibacterials. What's the implication of this action of phenytoin? Phenytoin, carbamazepine, valproate will be depleting the folic acid from human body by inhibiting this particular step, and you can get folic acid deficiency. Especially if these drugs are given to pregnant women, you know the folic acid deficiency leads to neural tube defects. So this is how this folic acid metabolism is getting integrated. Then there are antimalarial drugs like pyrimethamine and primaquine especially, and proguanil. These three drugs, they are also anti-metabolite, and they are inhibiting this second step. So there are various implications of this. For example, as I said, antimalarial drugs, you can see pyrimethamine here, and in the first box you can see sulfonamides. A sulfonamide is combined with pyrimethamine, that sulfadoxine pyrimethamine combination, for management of resistant malaria. Again, there is going to be inhibition of the two consecutive steps. When you inhibit the two consecutive steps, it's called sequential blockade, and it leads to drug synergism. So this is how we discuss what's the exact mechanism of action of sulfonamides, what's the step where they are acting, and various related issues. We move on to the next slide to write the mechanism of action, mechanism of resistance produced by the microorganisms to the sulfur drugs. Number one, now as you know, PABA is going to be the substrate, para-aminobenzoic acid. So what microorganism can practice is produce PABA, para-aminobenzoic acid, in large amounts. So that's overproduction of PABA, and this characteristic achieved could be by mutation. Next, what is your drug going to do? Is going to inhibit my folic acid. I'm a microorganism, okay. You're going to inhibit my folic acid. So why not produce my own folic acid? Why not synthesize? Why not get a folic acid synthesizing enzyme? Yes, some wise microorganisms do this. They produce a folic acid synthesizing enzyme, They are going to synthesize their folic acid as it is, but they will synthesize a different kind of enzyme which will be able to produce folic acid, and this enzyme will have less affinity for the sulfonamides. Very novel development of resistance. I am going to synthesize my folic acid, you are going to come and inhibit my particular enzyme. So I prepare an enzyme which will be helpful to me to form folic acid, but your drug cannot bind with that particular enzyme. So that's the second one, production of a folic acid synthesizing enzyme. Number 3 is impermeability, so either affecting the transport mechanism, efflux mechanism to throw out the drug, or to inhibit the permeability of the drug in the bacterial cell membrane. So these are the 3 common mechanisms of development of resistance by microbial organisms to the sulfonamides. And this is why we don't give sulfur drugs alone. They are always combined with the drugs acting on the second step. So I am calling it DHF reductase inhibitors. That's the second step. So sulfonamides act on the first step and inhibit the PABA reductase, or for that matter inhibit conversion of PABA to DHF, and you need to always combine sulfonamides with a DHF reductase inhibitor so that there is sequential blockade and there is no chance to the microorganism of developing resistance. So due to these problems of resistance, sulfonamides are not used as sole agents, they are not used alone. Let's go on to classify the sulfonamides. The first group is oral and absorbable. It means you give a drug by oral route and it's going to be absorbed and is going to go to systemic circulation and is going to produce systemic effect. There are short acting agents. The action lasts for 6 to 8 hours. That's sulfacytine, sulfadimidine and sulfisoxazole, not very commonly used these days. Then intermediate acting for about 10 to 12 hours. Why there is this longer action than short acting drugs? Because I've shown in the bracket PPP. That's they have got a high plasma protein binding. That's the reason. Example is sulfamethoxazole. You must pronounce this and remember this. This is a very important agent. Sulfamethoxazole. You also have sulfadiazine in this group, and you also have sulfamoxazole. All the 3 agents have got certain application in various illnesses and in various combinations especially. The third group is long acting, and look at the long acting. Look at the action. Look at the duration of action. They act for about 7 to 10 days. They are really long acting, 7 to 10 days, and they are highly plasma protein binding agents. And look at the names of the drugs. One is sulfadoxine and second one is sulfamethoxypyridazine. Sulfadoxine and sulfamethoxypyridazine. If you look at this slide carefully, I have made sulfadoxine bold, and this sulfadoxine is combined with pyrimethamine in various situations. I hope you remember pneumocystis carinii. I hope you remember malaria, and we're going to discuss this further. So remember this sulfadoxine, and this second drug which is made bold is sulfamethoxazole. This is combined with trimethoprim and you get cotrimoxazole. So these 2 drugs become important on this slide. We move on to the next group and the classification. This was oral and is going to produce systemic effect. We move on to the next group, and that's oral and non-absorbable. So you will take a drug by oral route of administration and it's not going to be absorbed. So what's going to happen is the drug is going to remain active in the gastrointestinal tract. It will also not be destroyed by gastric hydrochloric acid. Just to give you an example, it will be like neomycin, for example, which will have a local action. So oral and non-absorbable. The first substance is sulfasalazine. This gets broken down into 2 substances. One is sulfapyridine and the second one is 5-aminosalicylic acid, 5-ASA. So sulfasalazine is a combination of sulfapyridine and 5-aminosalicylic acid. Come on, we are not discussing the antimicrobial therapy here. We are discussing something else when I'm talking of sulfasalazine. Out of sulfapyridine and 5-ASA, this sulfapyridine is an active moiety in the management of rheumatoid arthritis. It's not directly related to the antimicrobial therapy, but since we are classifying sulfonamides, we came across sulfasalazine. So sulfapyridine is active moiety in rheumatoid arthritis, and the second substance, the second product, that's 5-ASA, 5-aminosalicylic acid, is an active moiety in the management of ulcerative colitis and inflammatory bowel disease. Ulcerative colitis and inflammatory bowel disease. So I hope you understand this is something different, and the active moieties are also different in the two conditions. Both the conditions, that's rheumatoid and ulcerative colitis, appear to be inflammatory disorders, but the active moiety is different. What we need to remember is sulfasalazine. Next is olsalazine. This is similar to sulfasalazine and is going to liberate 5-ASA, and it is better tolerated. So this group is not very important as far as our combinations with trimethoprim or pyrimethamine is concerned, but has got its own importance in rheumatoid arthritis, ulcerative colitis, and IBDs. The next group is the topical sulfonamides used for local effect. Topical sulfonamides used for local effect. First one, very commonly used, is sulfacetamide, available for eye and ear infections. It's available as cream, ointment, powder in various formulations, and is useful also for burn and wound dressings. You have a sulfonamide without the alphabets or without the word sulfa in its name, and it's mafenide acetate or mafenide hydrochloride, but it's a sulfa structure. So this is another topical antimicrobial sulfa agent. Next is silver sulfadiazine. You must be conversant with this. And the next one is sulfafurazole. Both of them, along with mafenide, are useful in the dressing of the wounds and dressing of the burns. So that's about the classification of sulfonamides. Let's move on to the adverse effects of sulfa drugs. Very characteristic, and the first one, very important, never to be forgotten, is allergic reaction. This sulfa moiety is very susceptible and leads to the allergic reactions. Allergic reactions could be very severe. Number one, in the form of Stevens-Johnson syndrome, and the Stevens-Johnson syndrome could be fatal. It's erythema multiformis with toxic epidermal necrolysis. It's a very severe condition. If it progresses fast over a period of 2 to 3 days, the condition could be extremely severe, and this could be fatal. You need to take care. If there is sulfa allergy, you need to remember about your patient. The next hypersensitivity reaction, allergic reaction, could be fixed drug eruption. The fixed drug eruption means if you have taken a sulfa drug in past and you got a lesion due to the hypersensitivity reaction. For example, you get the blackening of the lower lip here. If you got this lesion, then you understood, I am allergic to sulfa. You stop taking sulfa. But then it's likely to happen that after years, you have forgotten this particular issue, and by error, you have been prescribed a sulfa drug once again. If you take a sulfa drug, even after years, you get the same type of lesion at the same site. That's miraculous. So this is called fixed drug eruption, because the site is fixed and the drug is fixed. So that's fixed drug eruption. Next, you can get Kabler phenomena. If you get some injury or if you get some damage on the skin anywhere, if you get some trauma, then at this particular site, you are going to have skin lesions. If you are receiving sulfonamides, if you have received the sulfonamides, you will be susceptible to this. That's called Kabler phenomenon. Next, it can produce exfoliative dermatitis. We already mentioned Stevens-Johnson syndrome, and exfoliation is seen in various conditions out of this. So exfoliative dermatitis, morbilliform rashes, and urticaria can be seen. What are the various substances which have got sulfa structure and you can expect allergic reactions if you are allergic to sulfa? That's number one is sulfones, that's dapsone. Next one is acetazolamide, thiazide, and loop diuretics, all of them diuretics. Carbonic anhydrase inhibitor, thiazide, and furosemide, loop diuretic. Then diazoxide is an antihypertensive agent, a vasodilator, and then sulfonylureas, which are oral hypoglycemic agents. All of them, they show cross allergy or cross hypersensitivity with sulfa drugs because they have got a sulfa structure. So you need to remember this for your patient. You need to have the clear-cut drug history of your patient and the history of allergic reactions. Secondly, The drugs can produce photosensitivity reactions. It's also commonly known with sulfonamide group of agents. The next adverse effect, of course, is hyperacidity, nausea, vomiting, and diarrhea, common to sulfonamides. They are acidic in nature, and they can increase the acidity, lead to nausea, vomiting, also diarrhea. Just because of this acidic nature, you can also get a similar kind of effect, but in the urinary tract. And the patient could experience burning micturition and formation of crystals. So it's called crystalluria. The patient could have proteinuria and sometimes hematuria due to the neutral or acidic urine. So these drugs are acidic in nature, and if the urine is neutral or acidic, the patient is more susceptible to get crystalluria, proteinuria, and hematuria, and long-term use can lead to some renal damage. Now we need to avoid all this, so a general precaution will be, if the patient is receiving a sulfur drug or a combination with sulfur, patient should drink plenty of water. That's one simple precaution which could be taken. And you can give alkalinizing agents to keep the urine alkaline. So these are two precautions which could be taken. Number 5, the next adverse effect is hemolysis in G6PD deficient patients. That's known with sulfonamides. That's also known with fluoroquinolones. I hope you remember. Next, sulfonamides can produce rarely kernicterus in the newborn. If sulfonamides are given during pregnancy, especially during the second and third trimester, they compete for bilirubin for the plasma protein binding site, and the bilirubin will be displaced, and bilirubin levels will be very high, and there will be defective conjugation because the newborn does not have the enzymes required, the liver is not yet developed, so the conjugation will be faulty and the bilirubin will remain unconjugated. This is going to lead to production of jaundice. This bilirubin can further enter the central nervous system and can produce severe CNS effects, which we call as kernicterus. So that's kernicterus in the newborn, and this is known with sulfonamide group of drugs. Look at that, one drug interaction of displacing bilirubin from the protein binding sites, and because the newborn cannot conjugate, cannot break it down, you are getting this adverse effects. That's kernicterus. You can use barbiturates, which are the inducers of the cytochrome P450 enzyme system, especially CYP3A4 system, to stimulate the enzyme system and to facilitate the conjugation of bilirubin. So that's kernicterus in the newborn. Next, because they have got folate antagonistic properties, they can produce folate deficiency and megaloblastic anemia. We need to know they are highly plasma protein binding drugs, number 1, and there is a urinary antiseptic called methenamine. If you give sulfonamides with methenamine, then there could be antagonism, they could have opposite effects. Let's move on to the next slide. What are the combinations of sulfa with other drugs? And this is going to produce less resistance and going to produce drug synergism. First, most important combination is cotrimoxazole or cotrimoxazole. Co is a combination, and the word contains trim and oxazole. Trim comes from trimethoprim and oxazole comes from sulfamethoxazole. So it's a combination of trimethoprim plus sulfamethoxazole, and it's in the ratio of 1 part of trimethoprim and 5 parts of sulfamethoxazole. 1:5. 1 part of trimethoprim and 5 of sulfamethoxazole. So the formulations of various tablets which are available is 80 milligrams of trimethoprim and 400 of sulfamethoxazole, because it's 1:5. Then the double strength tablet is 160 milligrams of trimethoprim and 800 of sulfamethoxazole. Then 40 milligrams of trimethoprim and 200 of sulfamethoxazole, which will be a tablet useful in pediatrics. That's a pediatric tablet. And still smaller tablet, 20 milligrams of trimethoprim and 100 milligrams of sulfamethoxazole. Everything available as syrups, tablets, and injections. So this is one important combination. Starting to discuss cotrimoxazole, which is a combination of trimethoprim and sulfamethoxazole. Trimethoprim to sulfamethoxazole in the proportion of 1:5. 1 part of trimethoprim and 5 parts of sulfamethoxazole. So there are various strengths of tablet available. 80 milligrams of trimethoprim and 400 milligrams of sulfamethoxazole is the most common formulation available. Let's have a look at the slide. What's the mechanism of action of this cotrimoxazole? There are two components in this cotrimoxazole. One is sulfa, please follow the cursor, and the second one is trimethoprim. Sulfa inhibits the first step in the folic acid metabolism. That's PABA to folic acid. Folic acid could also be called as DHF. This step is inhibited by sulfa. Folic acid to folinic acid, that's DHF to THF, is inhibited by trimethoprim. Hard to remember, sulfa inhibits which step and trimethoprim inhibits which step. At the last moment you may be confused. A simple method. Look at the alphabets, how they come. P, Q, R, S, T. So S comes first, T comes later. So put S for the first step, that's sulfa, and put T for the second step, that's trimethoprim. So you won't commit a mistake on this. So that's the mechanism of action, and look at the greatness of this particular combination. If you use sulfa drug alone, then probably the microorganism can learn to overcome the inhibition by sulfa. So you just get a bacteriostatic effect. Suppose if you use trimethoprim alone, again you just expect a bacteriostatic effect. But when you use them in a particular ratio, that's 1:5, 1 part of trimethoprim and 5 of sulfa, you start inhibiting the two steps in sequence. So that's called sequential blockade, and this leads to drug synergism, and the combination becomes chiral. So let's go to the next slide to see what are the advantages. What is this synergism and what are the advantages? Number one, the sequential blockade, so that the individual drugs are static but the combination becomes bactericidal. The individual doses of those individual components, that sulfa and trimethoprim, they are reduced. There's reduced dose requirement because there's synergism, and the duration of action of this combination is increased. So naturally you get less frequency of administration to give the drug. So you can give the drug less frequently. This widens the spectrum of activity because you get the spectrum of sulfa as well as you get the spectrum of trimethoprim, and this combination has a better penetration in genital fluids and in the central nervous system, so that you could use this combination for the genital tract infection and CNS infections. So this is the drug synergism, and these are the advantages of combining trimethoprim with sulfamethoxazole. So that's cotrimoxazole. Uses: it's a drug of choice for nocardiasis, that's aerobic actinomyces gram-positive or higher bacteria, that's nocardia. That is useful for pneumocystis carinii pneumonia, that's a drug of choice for PCP pneumonia. Nowadays this pneumocystis carinii is called pneumocystis jirovecii. So it's for treatment and prevention. Next, E. coli, Protea, Salmonella, Shigella, Legionella and H. influenzae, all the gram-negative organisms, and you can use this drug for UTI, urinary tract infection, enteric fever, bacillary dysentery, meningitis and pneumonia. Cotrimoxazole is also useful for toxoplasmosis and listeria. It's useful for the genital tract infection and urinary infections. We already said UTI, prostatitis and vaginitis. It's useful for respiratory infections and the community acquired pneumonia produced by pneumococcus, H. influenzae, Klebsiella as well as various other microorganisms. The other combinations of sulfonamide include sulfadiazine, which has got good CNS penetration, along with pyrimethamine. So sulfa plus pyrimethamine for toxoplasmosis, for PCP pneumonia, for leishmaniasis and for resistant malaria. You use sulfadoxine plus pyrimethamine, 500 of sulfadoxine plus 25 of pyrimethamine, just 3 tablets as a single dose, again for resistant malaria, and this combination is also useful in toxoplasmosis and pneumocystis carinii or pneumocystis jirovecii. Lastly, you have sulfamoxazole plus trimethoprim. This is another combination just like sulfamethoxazole and trimethoprim. The cotrimoxazole produces certain adverse effects just like sulfonamides. It has a sulfa drug and trimethoprim. So megaloblastic anemia, leukopenia, granulocytopenia. Folinic acid is essential if the patient is going to be on cotrimoxazole for a long time, 6 to 8 milligrams per day. And in emergencies, you can treat the emergency That's because of the folic acid deficiency. You could get a severe toxicity or severe emergency, and you could use leucovorin or citrovorin factor to overcome this deficiency. All the adverse effects of sulfur drugs, including hypersensitivity reactions and others, could be expected with cotrimoxazole, so that rashes, diarrhea, sometimes transaminitis and hyperkalemia and hyponatremia. Renal damage can also happen with cotrimoxazole. So this was a discussion about sulfonamide and cotrimoxazole together, and we now go on to discuss some urinary antiseptics. These are special drugs useful for only simple urinary tract infection. Let's go to the next slide. I am putting the slide for you. Look at the various characteristics which I am showing you, and these are going to be important. So let's have a view at the slide. Urinary antiseptics are oral agents. They are used by oral route of administration for antibacterial activity in the urine. So they are oral agents, and the purpose is only to produce effective antibacterial levels in urine. There is little or no systemic effect expected with these drugs. So when to use them? They are generally used for uncomplicated acute cystitis and pyelonephritis. In lower urinary tract infections, for E. coli and Staphylococcus saprophyticus, and for chronic UTI where the short-term systemic therapy has failed. I hope you are understanding. This is not for very complicated infections. It's for uncomplicated infections in the lower urinary tract for E. coli and Staphylococcus saprophyticus, and sometimes for chronic infection when the short-term systemic therapy has not produced the effective response. The first drug is methenamine mandalate or methenamine hippurate. These substances, they release formaldehyde in the urinary tract, and this formaldehyde becomes sterile to the microorganism. This can be used for chronic suppressive therapy, mainly for lower urinary tract infection. Mandalate and hippurate both are used in the dose of 1 gram. Mandalate is given 4 times a day and hippurate is given 2 times a day. Acidifying agents are indicated to keep the pH 5.5 or less, because the drugs will be more effective in acidic urine. So you can give ascorbic acid 4 to 12 grams per day to maintain the acidity. Important thing to remember is methenamine should not be used with sulfa, because it forms insoluble compound with formaldehyde. And don't use it for protease organism, because protease are resistant. Next we go to the next urinary antiseptic, that's nitrofurantoin, useful against gram positive as well as gram negative organisms, and the drug is static in nature. It's rapidly excreted through urine in high concentration, so you don't expect the drug to go to systemic circulation in significant amounts. And again, for this drug, you need to maintain the pH of the urine below 5.5 to enhance the activity. So this drug is going to antagonize the action of nalidixic acid. So by chance you are using nalidixic acid for urinary tract infection, please don't use nitrofurantoin. Avoid this in combination. Nitrofurantoin can turn the urine brown, and it can produce anorexia, nausea, vomiting and hemolysis in patients with G6PD deficiency. The next urinary antiseptic under discussion is nalidixic acid. This is an older quinolone. I hope you remember the quinolones. The newer ones are fluoroquinolones. This is an older one. It's rapidly excreted through urine, and this drug is more active at alkaline pH. If you're paying attention, for the last 2 drugs we said they're more effective in acidic pH. This one is more active at alkaline pH. So it should not be used with the 2 drugs which we already discussed, methenamine or nitrofurantoin, because they are going to be active if the pH is acidic, and nalidixic acid is going to be active if the pH is alkaline. So this is regarding the urinary antiseptics. We discussed them in conjunction with cotrimoxazole, that's the sulfa group of agents. I am sure this module was useful to you, and I wish you good luck.